for our June public research webinar, which is focused on bowel cancer research. And we really greatly appreciate you coming, and it's great to see so many people registered for this talk. So just before we get started, just to run through some housekeeping, we obviously want this talk to be as interactive as possible. So if you guys have any questions, please do put them in the Q&A box. And this is different from the chat box that you'll see at the bottom of your screen. There should be a specific box called Q&A. It's either going to be at the bottom of your screen or the top of your screen, depending on what device you're working from. And if you have any questions at any point throughout the talk, just stick them in there. Shauna on my team is also on hand. If anyone has any issues, just message her and she'll sort you out. And just a reminder that this is also recorded. So to kickstart, it is my great pleasure to introduce our next speaker and my former colleague in UCD, Dr. Sudipto Das. And myself and Shauna got a sneak preview of his talk yesterday, and you guys are definitely in for a treat. Dr. Sudipto Das is an Irish Cancer Society alumnus. He was previously funded by us through an Irish Cancer Society research fellowship working on metastatic bowel cancer. Following on from that, then, Sudipto continued his research in the Royal College of Surgeons in Ireland, where he was awarded a prestigious Star Research Lectureship position in 2019. I'm delighted that Sudipto now leads his own research group in RCSI, and Sudipto is focused on gastrointestinal diseases in particular. And he is here today to tell us a little bit and give us a little bit of a taster on his latest bowel cancer research. So I'll pass over to you, Sudipto. Thanks, Phil.
Thanks a million, Claire, and thank you, Shauna, as well for organising this and inviting me for this lovely talk. It's always a pleasure to speak for the Irish Cancer Society. So what I'm going to do now, I'm just going to quickly share my screen. So and hopefully technology help. Yeah. Okay, so very good morning to all of you, and thank you all for joining today as well for this talk. Especially it's actually a lovely day, so it's actually nice to be sitting here looking out the window, looking at the sun, and actually giving this talk. So as Claire pointed out, I lead the gastrointestinal diseases group in RCSI, and what I really wanted to talk to you guys today about is some of the work that we've been doing over the last couple of years, specifically work that I started while I was an Irish Cancer Society fellow, and how we have kind of progressed from that. And I will kind of also give you a glimpse of some of the very recent work that we've completed in terms of colon cancer. So to basically begin with, this slide seems a bit naive given the context of the talk, but this is something that actually comes to my mind, specifically if we are sitting in a pub and you're interacting with people, and often we kind of get this question from, the conversation starts and people ask you what you're working on, and then eventually when they find out that you're a cancer researcher, there are two questions people ask you. One is, how far away are we from the treatment, and why have we not got a treatment for cancer yet? And to the latter question, my answer normally is that cancer, in fact, is not one, but in fact, it's a complex of several diseases. And this is true because unlike other disease types, cancer is inherently extremely complex. And scientists over the last several years have actually identified factors that in fact controls cancer's growth and cell growth in general. And this slide here just kind of gives you a little bit of a snapshot of the different factors that impact cell growth and tumor growth. So some of these, for instance, are changes in a person's DNA, whether these could be structural changes or chemical changes, cells becoming immortal, not dying on time, cancer spreading, growth of blood vessels, which allows a tumor to grow further, also changes in metabolism, a person's metabolism in general, and also very importantly, and something that has become a recent highlight, is how cancer cells actually evade immune destruction. So all of these factors are collectively called as the hallmarks of cancer. And this is actually a sort of a benchmark for scientists to actually work on cancer research. Now, within this context, my group essentially focuses on how cancer is spread, particularly in colon cancer. How can we stop that spread? More importantly, how do changes in the DNA impact this cancer spread and tumor growth as well? Similarly, how inflammatory processes or inflammation in general is responsible for development of tumors. Now, I kind of wanted to kind of reiterate of the fact that while these factors all seem to be independently contributing towards the growth of a tumor, there in fact is a significant crosstalk between them. And that's something that we are quite interested in. So coming back to the topic of the day, which basically is colon cancer, April was the bowel cancer month, and it actually has become really it has become very obvious now that colon cancer prevalence across the globe has increased as the years have progressed. And this is a snapshot from 2019, where essentially we are looking at incidences of colon cancer across the globe. So in this figure, as the bluer the color gets, the higher the incidence rates of cancer, of colon cancer are. And if somebody looks at this map to start off with, one of the first stark kind of observations one makes is the fact that the colon cancer rates, in fact, are higher in the first world countries compared to the second or third world countries. Now, there is an exception of Latin America here. However, and there are several factors that really have been attributed towards these high colon cancer prevalence or incidence rates in the first world countries. They have been associations with diet, exercise, lifestyle, particularly consumption of processed and red meat. All of these factors are still under study to essentially establish a direct association of these factors and colon cancer. Now, irrespective of where colon cancer incidences are, colon cancer still happens to be the most colon cancer essentially is one of the cancer types that has the highest death rates if we take out gender specific cancers like breast cancer and prostate cancers. So to give you a bit of an idea about how colon cancer develops. So colon cancer, in fact, is one of the cancer types which develops in a very systematic form. So as you can see in this figure here, it starts from development of a polyp in the colon that then progresses on from stage 1, 2, and 3. And this is when the primary tumors begins in stage 1. And as this tumor grows and reaches to stage 4, this tumor essentially then starts spreading its tumor cells to other organs. And in colon cancer, liver becomes the first site where the disease essentially spreads. And this disease spreading to the other organs is termed as metastasis. Now, if we come a bit closer to home and look at the National Cancer Registry of Ireland and the data that they had published, particularly the statistics that were published from 2010 to 2014, I just want to bring to your attention the statistics for colorectal cancer, looking at all the different stages. Now, what is really impressive and encouraging rather is that if we look at the survival rates of patients from stage 1, 2, and 3, you can see the survival rates in fact are quite high, ranging all the way from 67% to 95%. Now, to a great degree, this can actually be associated with the fact that we in fact have a very active bowel screening program. So patients are screened earlier, they are detected earlier, and basically treated earlier. However, in contrast to these early stage colon cancer stages, you can actually see that the rate of survival in stage 4 cancer patients is in fact very poor. It's only 12%. And this is in fact quite worrying. And this kind of stems from the fact that our understanding for stage 4 colorectal cancer is still growing, and we still have a lot of work that we need to do in this area. So, moving on from there, one of the first questions that our group essentially tries to ask is that how do we better diagnose and predict disease spread in colon cancer patients? So keeping this question in mind, the work that I started back in 2013 as an Irish Cancer Society Fellow was looking at specific changes in tumor development. Now, to give you a bit of context as to how these changes in our genes or DNA can actually lead to tumor development, if we say, for example, look at a normal cell, where you basically have an intact DNA. The DNA is present intact. The genes are functioning as normal, which will mean that as the cells divide and as they grow, ultimately the cell reaches its end point, the cells undergo cell death, and this is particularly a sign of a normal healthy colon or any normal organ. But this is something that completely changes when it comes to cancer. So if you look at a cancer cell, you essentially have changes in the DNA. Now, this change in the DNA can be a physical change in DNA, like mutation, say for example, and these changes are broadly classified as genetic changes. On the other hand, you can also have chemical changes or chemical modifications in the DNA. Herein, while there are chemical modifications in the DNA, they are no structural changes, but in fact the message that the DNA is conveying changes. And these chemical modifications are called as epigenetic changes. Now, irrespective of these changes, what we do know is that as these changes progress and as these changes in fact grow, you will see an uncontrolled cell growth. Now, this is quite different from what happens in normal circumstances where cells undergo cell death. In this case, because the DNA is not intact and is undergoing genetic or epigenetic changes, the cells grow uncontrollably, which then gives rise to a tumor. And this is something that we see in various cancer types, including colon cancer. So bearing in mind these changes, our group essentially is focused on looking at how these chemical changes impact tumor development, and can we then utilize these epigenetic changes to develop new treatment options and to better diagnose patients. So as I mentioned, as an Irish Cancer Society fellow back in 2013, we had started some of this work specifically looking at one such epigenetic change or chemical modification called DNA methylation. Now, to look at this, what we did essentially was we took a cohort of 55 metastatic colorectal cancer patients, basically colon cancer patients who have metastasized to the liver. We took their tumor, extracted their DNA, and then we carried out quite a state-of-the-art work when we started measuring or looking at all these DNA methylation changes in the tumor versus the normal tissue. And what we did identify that there are 376 sites on the DNA isolated from these patients that actually have a very distinctive methylation pattern that is unique to the tumor compared to the normal. What was more interesting for us is when we asked the question of what do these chemical modifications do? As I mentioned in the previous slide, that these chemical modifications, while they don't change the structure of the DNA, they in fact change the message that the DNA codes for. So in that context, when we looked at these DNA methylation changes, what we did see that the DNA methylation changes on these sites, in fact, leads to an overactivation of genes. So that means certain genes that are actually present, that are meant to, that are normally silenced or normally turned off in normal cells, they become activated. And as a result of this activation, this causes the tumor to grow further. So the other kind of observation that we had from this study is that the cohort of patients that we basically had was a mixed cohort of patients. And when we started looking at the DNA methylation profile for these 376 sites for each individual patient, what we realized was that we could actually segregate this patient group into 4 different subtypes. In that, each subtype of patient will actually have their unique DNA methylation fingerprint, if you will. And then the question becomes, is that given the fact that each subtype of patients have their own DNA methylation pattern or fingerprint, can this unique DNA methylation pattern for each subtype be utilized for future diagnosis and treatment, and also understand the disease complexity? So basically what we do want to ask is, how are these subtypes different from each other, and can the unique DNA methylation fingerprint that is present for each of these subtypes be utilized to better diagnose, stratify patients, and ultimately better treat patients? So where are we with this now? So where we are with this now is that we are trying to basically evaluate both the diagnostic and the therapeutic potential of these 376 sites that we have identified. So in particular, from the diagnostic side, what we are doing is that we are testing these 376 sites and how their methylation status, or how this methylation fingerprint behaves in a much larger cohort of metastatic colorectal cancer patients. And ultimately, this will allow us to answer the question in terms of, can these sites be used to better predict diagnosis and disease prognosis as well. We are also trying to evaluate if these sites could be utilized as a potential therapeutic target. So to do this, what we are doing is that we are growing cancer cells in a dish, and we are now carrying out a gene editing or a strategy which essentially allows you to remove these sites from the cells. And I believe some of you might be aware of this technique, which is called as CRISPR, that essentially allows us to systematically delete or add genes individually in cells. Now, once we do that, you have 2 different scenarios. Either there are certain sites that will cause cells to die, once they are deleted, and there will be sites that once they are deleted, the cells will grow uncontrollably. The question that we have then is that which sites essentially causes cells to die, which will basically be a replicate of what happens in normal circumstances, versus which sites actually causes cells to survive, which is what happens in the case of cancer. And ultimately, once we have identified these different sites that actually either are involved in cell death or cell survival, we then will ask the question, can we develop certain treatment options for these sites? And more importantly, do these sites in fact have a therapeutic value? So I just want to kind of shift gears here. And the other kind of question that we are asking within our group is that how do we improve the existing treatment options for colon cancer patients? Now, to basically answer this question, we need to look at how patients are currently treated or were historically treated over the last few decades. So over the last few decades, what clinicians as well as scientists, what they believed is that if you take any kind of cancer patient cohort, whether it be colon, breast, or any cancer type, the assumption there was that while it is a cohort of patients, it is a collection of patients. However, all these patients have the same cancer type. So the presumption there was that if we give the patients a single kind of treatment, so say for example, you have 100 patients who have stage 2 colon cancer, if they are given a certain treatment that is targeting stage 2 colon cancer patients, the idea then will be that given the fact that they all have the same cancer type, we should be essentially expecting a similar kind of effect for all these patients. In fact, that is not the case, in that some patients do have an effect, whereas some patients don't have an effect. And in fact, there will be patients who will have adverse effects to these treatments. And this is what we term as a one-size-fits-all approach, or rather imprecision medicine. And where we are trying to now move or depart from this is into an era of precision medicine. Here, instead of looking at these patients on a population basis or looking at the patients who have got the same kind of disease, we are in fact looking at these patients individually and trying to understand what is unique to these patients in terms of their features, whether it be their lifestyle features, whether it be their genetic features, and how are these patients uniquely different from each other. And this we are doing using several different diagnostic tests, whether that be blood, DNA, urine-based test, or tissue-based test. And ultimately, the idea is that once we have identified these patients who have similar kind of characteristics, rather than classifying them under the same umbrella term of the same cancer types, we now start looking at how are these patients similar in certain contexts. And ultimately, the idea here is that you then start tailoring your treatment or personalizing your treatment based on these individual patients' makeup. And going from there, the idea would be that once we have personalized this approach, we kind of, to a certain extent, mitigate what we see in the scenario above here. And you are essentially looking at an effect where these patients have a reasonable effect to this treatment. So while we are trying to move to an era of precision medicine, there are certain challenges that we do face. And one of these challenges is that if we look at any cancer cohort wherein treatments are being designed or diagnostics strategies are being designed, these patient cohorts, and in fact, there is a large amount of disparity in these cohorts. Now, this could be patients who have different age, different gender, but one of the very important criteria that most cancer studies, in fact, fail to address is the fact that there is an ethnic diversity. Rather, there is a difference in ancestry between these patients. Particularly from the aspect of colon cancer, what we do know is that colon cancer patients who come from an African ancestry, in fact, have a poor prognosis compared to patients who are coming from a European ancestry. So the biggest question that in fact plagues the colon cancer field is that why are these patients so different in terms of prognosis? So to answer this question, our group essentially has utilized one of the most important repositories of data that actually has been curated to date in the area of cancer research, and which is termed as the Cancer Genome Atlas. So what the Cancer Genome Atlas really is, it is a collection of data, genetic data, clinical data, about proteins, and lifestyle factors as well across 12 different cancer types and thousands of patients from across the globe. So essentially, it's a collection of all these data sets. So what we did was we took the colon cancer data from this cancer genome atlas and we analyzed this further, breaking the patients down by ancestry. And we essentially asked three questions. The first question was, which genes are turned on and turned off if you were to compare these two varied ancestry groups? Is there a difference in anti-cancer immunity between these patients? As well as the fact that, you've probably already seen, that my group is quite interested in looking at the DNA methylation changes. We also wanted to ask that, do chemical changes in DNA, such as DNA methylation, in fact differ between these two groups? And do they contribute as well to this observed disparity between these two patient groups? So what did we find? So what we have found so far is that in the patients colon cancer patients who come from African ancestry, they in fact have a low anti-cancer immunity. In that specifically, when cancer develops in our body, naturally we have certain cells called killer T cells. So when a cell becomes infected or a cell becomes cancerous, the job of these killer T cells is to kill these cells, and ultimately the infected or the cancer cell dies. So in the case of colon cancer patients, the number of these killer T cells, or what we call as cytotoxic T cells, is actually quite low in comparison to colon cancer patients who come from European ancestry, where they actually have an abundance of these killer T cells, and therefore they have a high anti-cancer immunity. So the biggest question for us was that, what is controlling this low anti-cancer immunity, or what is actually causing this difference in anti-cancer immunity between these two patient groups? So when we did our analysis, one of the first findings when we asked this question was that there are certain molecules that are called as master regulators. Now, what these master regulators do is that they in fact control a cascade or a pathway of genes, such that these master regulators, as shown in this image here, these master regulators might turn on or switch on gene A, which in turn turns on another gene B, and ultimately this gene B has an impact on immunity. And what we see is that there are certain master regulators that either are turned on or turned off in the case of colon cancer patients, that control these cascade of events and ultimately leads to this low anti-cancer immunity in these patients. Similarly, what we also find is that there is a significant difference in the DNA methylation, or the chemical modifications in the DNA, between the two patient groups, which also contributes towards this low anti-cancer immunity. Ultimately, our idea is that now that we've identified these key differences, and we have kind of to a certain extent identified factors that contributes towards this anti-cancer immunity, can we then tailor the patient's treatment and diagnosis using these master regulators? So one thing that I did want to leave you all with is something that we have realized, and in fact the entire scientific community has realized over the last couple of decades, that for any kind of research, and in our context particularly for cancer research, collaboration plays an absolutely pivotal role to improve the overall quality of life of patients. And we have been extremely fortunate that we have had collaborations we have had invaluable support, in fact, from clinical collaborators at the various hospitals within Ireland, whether it be the Mater, St. Vincent's or Beaumont. We have an extensive collaborative network with other academic research institutes within Ireland, like Trinity, UCD, as well as international institutes as well. More importantly, we also have industry support, and very, very vitally and crucially, which is for us, which becomes very important, is that we have support from the patient advocacy groups and from funding bodies like the Irish Cancer Society. And all of these different factors and all of these different collaborative initiatives ultimately allows us to improve the patient's journey by improving diagnosis and improving treatments from our strategy. And ultimately, our goal is that as these years progress, and as our research progresses further, we are able to improve the quality of life of patients, for cancer patients. So with that, I would like to say a massive thank you to the Irish Cancer Society for their absolutely amazing efforts that they have pulled for the last couple of few years, supporting not just scientists like us, but supporting big research groups as well as PhD students as well. And more importantly, a big thank you and a big shout out to the public for actually continuously supporting Irish Cancer Society. Your support is absolutely invaluable for us to drive our research forward. So with that, I'm going to stop, and I am very happy to take any further questions. Thank you.
Thanks so much, Sudipto. That was an excellent talk, really brilliant and really easy to understand. So thanks very much. Just a reminder to everyone to put their questions into the Q&A box. We already have a good few questions there, so it's great to get the questions. But if anyone has any more, just please do put them into the Q&A box, and we'll get to them and we'll ask Sudipto. I suppose I might kick off, Sudipto. So I suppose in this talk, you talk a lot about epigenetic changes in bowel cancer. And sure. For people, I suppose, who are members of the public who are not necessarily as familiar with these chemical type changes, you tend to hear about the more physical changes of DNA and mutations. I think it'd be useful to maybe just explain a little bit more about that in terms of how these changes happen in a person.
Yeah, so these changes, in fact, actually are quite dynamic in nature compared to mutations. So there are several factors that actually have been associated with these chemical modifications. Some of them have been environmental changes. Some of these are diet-induced changes, lifestyle-induced changes. So unlike mutations, which are kind of stable, these changes actually are very dynamic. They do change in the life course of a person, even in a normal person as well. They actually do change. And one of the simplest examples that I normally give a person is that you actually have cells in your body. So if you think from a point of view that the cells, how does a cell know that it is actually supposed to secrete pigment and become a skin cell versus a cell that's supposed to become an eye cell? So the way this kind of what triggers or what causes a cell to become a specific cell in the skin versus something in the eye are actually these chemical changes. So these chemical changes can be either, they are signals in the body that actually causes these chemical changes to evolve as a person, if a disease develops or as a person grows older. But more importantly, you do have external changes as well that actually can cause or induce these chemical modifications.
Thanks, Sudipto. That's really useful. We've got a few questions here, loads actually. This is great. From Rob, this is a great presentation. Thanks, Sudipto. I suppose this kind of speaks to the nature of these chemical changes again. Sure. We obviously talked about the 4 different methylation profiles and how you can kind of group the 4 different subtypes. And we have a few questions on this particular question about the 4 different subtypes. Sure. And I suppose Rob is wondering, again, coming down to kind of what causes the changes, but what causes the changes in these specific subtypes? Is it due to underlying mutational landscape? Is it spontaneous or treatment in terms of how you're driving those 4 different methylation profiles? Yeah,
that's a really interesting question. And that's a question that we really have been trying to answer. Now, one of our challenges, particularly as I mentioned, was that the actual cohort of patients that we started working with, where this signature actually came from, is actually quite small. So for us to kind of make any kind of associations with clinical factors like treatment, say, for example, has been challenging. And that's what, our idea is that when we start kind of, to an extent, examining this signature in a larger cohort of patients, we will try and, so our idea is that we want to ask the question, does treatment inform or is treatment impacted by these subtypes? So say, for example, I talked about the 4 subtypes. So when we did look at these 4 different subtypes quite closely, one of the things that we did see that 2 of these subtypes, in fact, one of these subtypes seems to be associated with immunity, and the other subtypes seems to be associated with metabolic changes. And these are all the way we kind of delineate or kind of identified how these subtypes are different is based on the genes that are turned on and turned off in these subtypes. So for one of the subtypes, the genes that are predominantly turned on are the ones that actually control immunity, whereas the other ones, the other subtypes, the genes that are in fact turned off, are the genes that control metabolism. So our question now is that since we know that these chemical changes in fact impact, genes being turned off or turned on, the question now is that do these chemical modifications, DNA methylation particularly, impact these characteristic features that we see in these subtypes? So it will be the treatment, whether it be prognosis, or particularly as well these subtypes, the nature of these subtypes in general. Does that answer the question?
Yeah, absolutely. Thanks, Milsted. And I suppose on the point again about those 4 different subtypes, so somebody made the point of, obviously you've got these DNA methylation profiles, but do you need to take other epigenetic changes into account to accurately kind of separate these patients into the different subtypes and actually see a clinical benefit?
That is very true. Yes, that we are only looking at DNA methylation as an epigenetic change. There are other epigenetic changes that happen as well in patients. So that is absolutely critically important that we do take that into consideration. So we are looking at other epigenetic changes, to kind of factor that in as well between the different subtypes.
Brilliant. That's really good research. And I suppose this is, the question we always get asked, and it's a hard one to answer, Sudipto, is when could this work be used to inform clinical decisions leading to an actual clinical change?
Yeah, so I mean, we are kind of progressing this work quite steadily as we speak. So as I said, we do have a lot of support now from our clinical colleagues. So as we said, once we have validated this signature in the larger cohort of patients, we will be in a position to essentially, try and once this goes through the larger cohort of patients, the next step for us will be to start clinical trials, looking at how the signature, even if there is a subset of these sites that actually have a predictive potential, we then can start clinical trials trying to assess if we can. One of the questions that we are really interested to answer is, can this in fact predict which patients will progress into developing metastases versus which patients won't? And for that, we actually do have a really interesting cohort of patients that we are trying to recruit in the Mater Hospital. And once that recruitment is completed, and once we have basically started looking at our signature in those two cohort of patients, so patients who progressed versus patients who haven't, that will then give us this answer, and then we should be able to take it to the next step forward.
Excellent, thanks, Sudipto. So I was really interested in the work you're doing, looking at, the differences in bowel cancer prognosis in different ethnicities and in different populations, and I think that's
Sure.
really important work. We really need to make sure that we are designing our therapies for each individual patient and individual populations. And I suppose I read a study recently about how people from African American populations tend to have these kind of and I know I'm going to use jargon, so apologies, I will explain what I'm saying, have this kind of accelerated epigenetic aging on a particular side of their colon. So they have this, what we call these, they have a lot of these changes on a particular side of their colon, on the right side of their colon. And there's a bit of a kind of a theory that maybe this might explain why, they are more likely to get tumors on the right side of their colon, or why they're more likely to get cancer early on. And I suppose, have you looked at anything like this? Do you see anecdotally that, like, when you look at, tumors from this population, that they tend to come from the right side versus the left?
The
Is that something
answer
you
is
see?
yes. So what we basically did was, when we looked at our data in general from the Cancer Genome Atlas, the idea was that if we divided the patient based on their ancestry, what is different from them? So we looked at stage, we looked at age, and we also looked at, as you said, location of the tumor. So what we do firstly see is that patients who have coming from the African ancestry, in fact, tend to be younger. So that means they are actually less than 50 years of age. And this is something that actually has been highlighted in colon cancer field, is that in over the last 2 decades, really, we have seen higher incidences of younger population of patients actually getting colon cancer. But coming back to your question, Claire, we do see that majority of the African patients from the African ancestry, in fact, have a prevalence for right-sided colon tumors being developed compared to the left side. And we also actually do see that there is a difference in the anti-cancer immunity in the right versus the left side. So that's something that we are kind of looking at quite closely, and that is an association that we are trying to make from that point of view as well.
Thanks, Sudipto. Going back to, we've got loads of questions here, which is great. So we have a question here about, do people who have inherited the cancer genetic defect called Lynch syndrome respond better than the normal population to immunotherapy treatment? And I suppose, just in terms of treatment questions, really kind of clinicians can only really answer very specific questions on treatment. But Sudipto, you might say if you know of any particular research that shows there might be, evidence for response in Lynch syndrome patients.
Yeah, particularly with regards to immunotherapy, I'm not quite aware, but what I can definitely say is that our my group also works on inflammatory bowel diseases, which in fact is one of the causative is associated as a causative or a predisposing condition rather to colon cancer. But particularly with Lynch syndrome, what we have seen, and these are kind of studies that we have come across, is that the chemical modifications, the DNA methylation changes that I talked about in colon cancer, is very much prevalent in Lynch syndrome as well. And in fact, there is a bit of a commonality in certain genes which are turned on and turned off between Lynch syndrome and colon cancer as well. So coming back to the question of immunotherapy, the precedence of giving a patient immunotherapy or not really depends upon a large number of factors. So I think with regards to Lynch syndrome, my best guess would be that compared to colon cancer, where you do see a lot of instability in terms of their general immune environment, Lynch syndrome actually might not have that high level of dysregulation of immune system. So I'm not quite sure if giving immunotherapy to Lynch syndrome patients, basically would be kind of a treatment of choice as opposed to the colon cancer.
Thanks, Sudipto. And just a reminder, if anyone has any specific treatment questions or you want to find out more, I would encourage you to contact and ask your clinician directly, and they should be able to answer treatment-specific questions. I suppose that leads kind of nicely onto what my next question was about, like, obviously the work that your group does in other inflammatory bowel diseases. And you've already answered the question a little bit, but I'd really be interested to know, with the learnings you gather here on bowel cancer research, can it also be translated and linked to other diseases of the bowel? So you've talked about Lynch syndrome, but for example, other different diseases.
Yeah, Claire. So basically, as I said, like our group kind of looks at gastrointestinal diseases in general, and in particular, what we do have is that we are working on a form of inflammatory bowel disease called ulcerative colitis, or colitis as people would normally know it. So basically, ulcerative colitis is one of the kind of key features of ulcerative colitis is the fact that there is a massive inflammation in the colon. And what we do know is that 4 to 10% of patients who actually have colitis can develop what is termed as colitis associated cancer, which then develops colon cancer as time progresses. So there are studies in the past, particularly clinical trials that were run in UK, where they have identified genes whose where the DNA methylation changes in those genes is actually evolves as the patient's colitis evolves to colon cancer. And this essentially is one of the goals of our group, is that we are trying to bridge this gap, or trying to answer the question that what is common, between colitis and cancer and colon cancer, and can that be explained, or does that, or what is different even from that point of view, and can that explain to a certain extent how an inflammatory disease which actually has no cancer has no kind of, there are no cancer cells there, how does that eventually evolve and develop into colon cancer? So I think the answer, one of the questions from our end, what we're trying to do is look at the similarities and dissimilarities in the DNA methylation profiles between ulcerative colitis patients, colitis associated cancer patients, and colon cancer patients as well.
That's really interesting. So the idea would be that, for example, if you were affected by colitis, you might be able to, based on your methylation profile or these changes, predict whether you're a patient that's likely to progress to
exactly
colorectal cancer. In that sense, then you'd at least kind of be able to address the issue and have more increased screening, for example.
Yes, absolutely, definitely.
Brilliant. So we have another question here. So what is your opinion of looking at circulating tumor DNA in managing colorectal cancer progression after surgery and or chemotherapy? You might just explain, Sudipto, to people what is circulating tumor DNA.
Sure.
And maybe just answer it from the point of view of, I suppose, what the research is, rather than, I suppose, again, it's quite a clinical question, but if you can answer, if you know about any particular research.
It's a brilliant question. So so first and foremost, what circulating tumor DNA is that if you think of a tumor and as it expands, the tumor cells shed. So, if once this tumor becomes quite large and it starts shedding these cells, the cells eventually break, and the DNA that is present within these tumor cells, they break out from the cells, and this DNA then goes into your circulation or into the blood. And this then gets transported from the primary site where the tumor is into other organs. And this DNA that is coming now, that has come from the tumors and now is in the circulation, is what we call as circulating tumor DNA. Now, why this has become so important from not just colon cancer, but across other cancer types as well, is the fact that if you think of the different diagnostic strategies that clinicians use to diagnose cancer, most of them involve taking invasive biopsies from patients, which are generally quite invasive in patients. That, if you compare that to a simple blood draw, if you just go to a doctor or a nurse and the nurse takes a sample of your blood, and then that sample of the blood can actually tell you what stage of disease you are at, is much preferable from a patient perspective compared to taking a biopsy. So coming back to the question, so that's why circulating tumor DNA has actually really taken a hot seat, if you will, in cancer, in the area of cancer diagnosis, because it is essentially a non-invasive strategy that can still allow you to identify and diagnose patients. So from the point of view of circulating tumor DNA, I think it's absolutely vital. And there are emerging studies where in fact people are looking at circulating tumor DNA. And when they're looking at this particular circulating tumor DNA, they're looking at not only the physical changes, so they're looking at mutations, but they're also in fact looking at DNA methylation as well. And then they're trying, what they are doing is they are deriving the DNA methylation profiles from the circulating tumor DNA versus the DNA that is extracted from the tumor itself. And they're looking at the similarities and dissimilarities between them. And if, say, for example, the pattern that you see from the circulating tumor DNA is the same as the actual solid tumor, then essentially you could use the circulating tumor DNA as a surrogate to predict how this tumor is going to develop. So within that context, what we are doing in our lab as well is that those patient cohorts that I talked about, which we are using as a validation cohort, for 50 of those patients, the idea for us is to extract out the circulating tumor DNA as well, to give us an idea that is our signature as valid on circulating tumor DNA as it is in the solid tumor. And that then actually, when we move on to clinical trials, hopefully in the next few years, we could then utilize circulating tumor DNA as an avenue essentially as well. So basically answering the question in a nutshell, I think it is absolutely critical of looking at circulating tumor DNA, particularly from cancer progression, because if you think the tumor is developing, right, the tumor is becoming bigger. So that is how cancer is progressing. So as the cancer progresses, the chances of you picking up circulating tumor DNA, especially in the late stages, becomes actually quite high. So we absolutely should utilize this avenue that we have come across.
Absolutely. But just, I suppose, to reiterate that the research is still quite at an early stage, so it needs a lot of further investigation before can see it in terms of clinical utility. But thank you so much, Sudipto. I've still got a good few questions, which is great. How are we doing for time? We're good. Sorry, we'll nearly stop grilling you soon, Sudipto, but everyone's very interested in your talk. So you talk a lot about epigenetic changes and these chemical modifications in relation to bowel cancer, but I suppose if we've any people or members of the public who are interested in other cancer types, are researchers looking at these type of patterns and changes for other cancer types?
Yeah, so as Claire pointed out, I used to work with Claire in UCD, and when I used to work in UCD, we were also part of RCSI Society's first funded consortium called Breast Predict. And within Breast Predict, one of the things that we were interested in was to look at these DNA methylation changes particularly in HER2 positive breast cancer patients. And we were interested to see as to how certain patients respond to a given line of treatment versus the patients who don't respond. So to come to your question, Claire, that is an example of where we have looked at it from a breast cancer perspective. There are several studies looking at pancreatic, prostate, and other upper gastrointestinal cancers as well, quite actively, in fact, looking at DNA methylation changes. And in fact, there is a funded, like myself, there was another funded fellow, Dr. Antoinette Perry, in fact, who's working on who's working on prostate cancer, and wherein she has in fact identified a certain number of sites whose methylation profile can be detected in the urine as well of the patients. So again, it is quite an evolving field. It is a really popular field, so to say, and it is becoming more and more important, not just in cancer, but also in non-cancer associated diseases as well.
Thanks, Sudipto, and I think that's a really important point to make for anyone that's interested in learning more about these epigenetic changes, that it is not just applicable to bowel cancer or cancer in general, it's applicable to a lot of diseases that affect humans. So thanks for clarifying. One final question, and look, I know we've all been impacted by COVID-19 pandemic, but somebody would like to know, how has your research been impacted by COVID, and are you back up and running in the lab Before you answer your question, I should point out that this time last year, when everything was shut down and all the labs were shut down, Sudipto was actually working behind the scenes at the weekends, making really important COVID-19 swab buffers for Beaumont Hospital. So not only does he undertake important bowel cancer research, but you also really help out at the time of the pandemic. So fair play to Sudipto. That was a really, really important thing to do.
Oh no, thanks, Claire. And look, it was basically all hands on deck at that stage. You know, we were basically in a global crisis, let alone a national crisis. So whatever little we could help. But coming back to the question of COVID-19, it did impact our research quite significantly last year. Obviously, as you said, the labs were closed, students couldn't access the labs. But I have to say, though, this was a time that, you know, as a researcher, you do a lot of work as you go along, and there are very few instances where one can take a backseat and actually look at your entire data and start making sense of it, or actually even ask other interesting questions beyond the scope of your research. So that's something that I would say is a silver lining to the whole COVID-19, is that it actually did allow us to take a backseat and look at, you know, the findings that we've had and also plan our research forward. So that was good. Yes, the kind of the negatives of that was that we had no access to the labs, but I have to say, though, we were back in action quite soon. So we basically had a gap of about 5 to 6 months that we actually didn't have access to the labs. But as we started going back, even though the access was quite restricted, going back to the lab with social distancing and minimizing the traffic in the lab itself, we are back up and running now, almost to full capacity at this stage. And we have to say, like, yes, I think it is time that we have lost, and we are really trying to play catch up. But look, you play catch up in whether COVID or not COVID, to be honest, because this is just, it's science is the field you're in. But yeah, we did get affected, but I think the students in general, or my team in general, I think they were quite happy to, you know, read. They were quite happy to kind of gain the knowledge that they required, and I think that was great in retrospect. A lot of them actually went in courses to upskill themselves, which I'm sure is going to benefit, you know, the research and their careers down the line as well. So it was actually all right, I have to say.
Yeah, it's great to see everything up and running. And I think that's important, because I think a lot of people, when you think of translational research or lab-based research, obviously picture researchers in the lab working away, which is really important. But also a lot of what researchers do is like sitting at your desk and your computer analyzing data, which is really important, and analyzing that data to inform on your future experiments and planning your experiments. And then obviously a lot of majority of researchers are depending on grant funding. So, you know, it actually takes a lot of time to write grants. So it was a unique, I suppose, time in order to spend doing those things. So I suppose it's good that research didn't stop. Lab-based research stopped for a little while, but there was also really important research happening in terms of looking at your data and planning for those really important experiments in the future.
Yeah, one of the things actually that did impact us, and actually it did actually impact us across the board, was the fact that the hospitals were actually not taking in patients. So given the fact that our research, as you rightly said, is very translation heavily patient focused, so for us to get the samples that we had envisaged that we would get in a certain period of time, you know, that we did fall short of that. And that is something that we are still trying to compensate for. And I think it will take us a while to kind of come back up to speed. So I think that is, from the clinical point of view, yes, that actually was a bit of a setback for us.
Yeah. And you know, obviously you have to get ethical approval and get regulation to do your experiments. Exactly. You know, there's a lot of delays in that end of things as well, but hopefully things are looking up in the next the next year. Listen, Sudipto, that was loads of questions. We better leave you and stop grilling you. That was excellent, and we really appreciate you taking the time to speak with us today. We will definitely have you back next year for Bowel Cancer Awareness Month in April 2022. So watch this space, and you can give us an update on your research. And absolutely. I'd like to also thank everyone for tuning in, and specifically Shauna for organising all of our talk behind the background. We really appreciate that as well. So listen, thanks so much, Sudipto. And we're getting loads of messages constantly saying how great your talk was. So very well received.
Thank you so much. And
bye,
thanks,
everyone.
Thanks,
have a nice day.
Everybody. Thank you.
See ya.
See ya.